Van?
Yes, well, good morning, good afternoon, good evening, wherever you happen to be in the world, and it's great to be in very good company with so many eminent speakers. Thank you very much. I know it's a Saturday, so we'll get right to it. I would like to start introducing my co-chair this time, Dr. Parishit Gogate. He has a very impressive curricula, and he only wanted 4 lines there. I think that over and above being the vice chairman for the International Society on ISMSICS, which that in its own right would be very important, he's received many awards for his community eye service. And he's an extraordinary surgeon, and we've coincided in many meetings, particularly with the International Society of Geographical and Epidemiological Ophthalmology. So he's not only a good surgeon, but also a good speaker and a good teacher and a good researcher. So welcome, Parikshit.
Thank you, Professor Van. And I think I have to introduce you, Professor Van.
Yes.
you need no introduction for the international audience, because you've been working with the International Council of Ophthalmology for past 2 decades, and you have worked with so many.
I think you got muted there.
Yeah, but I mean, for the Indian audience, Professor Van Lansing is based in Mexico. Though of course, he's worked in different parts of the world in the past 3 decades. He has been one of the forebearers, I mean, on the forefront of international ophthalmology, fostering collaborations in research and academics. And now, of course, he's with a university teaching hospital. And he has been the face of HelpMeSee and advising HelpMeSee as its medical advisor for almost past decade. And in a way, this seminar is unique because it is about teaching cataract surgery in these difficult times. The International Society of Manual Small Incision Cataract Surgeons has always been for promoting quality cataract surgery, especially SICS all over the world. And HelpMeSee has developed this unique simulator in the past decade, and it's been especially productive, prolific in the past 7-8 months, where they have for the first time a simulator for SICS. So we'll have speakers speak about this. So I'll hand it over to my chair again, Professor Van Lansing, so that he can take it forward.
Great, thank you, Richard. And I'll try to share my screen with a very short presentation and actually just be ready just in case it decides that it doesn't want to share. Okay. Okay, can you see my screen?
Yes, ma'am.
Yes. Okay, great. Well, thank you very much, everyone. And it'll be a short presentation just introducing HelpMeSee, although Birgit has been very kind to do that. So essentially, we see ourselves as an instruction and educational institution that will help train more surgeons for the future, because as you know, cataract is still the leading cause of blindness, and most likely will remain that way unless we do something very aggressive in the future. Obviously, no presentation about HelpMeSee will be complete unless we speak about our first chairman and founder, Al Ucci, who many of you also knew him in his times of Orb as being also the founder and the mastermind. But he had this vision that pilots could be trained very safely, and that's how he developed flight safety, using simulation-based training for pilots. And the same concept, he wanted to apply it for cataract surgeons training. So obviously it's okay, how can we train people in a cost-effective procedure that is, do it in a safe way, and that we can scale it up. A lot of people say that the time taken is very quick. probably even quicker than a phaco because you don't have to change tubing, you don't have to do a lot of things. I don't like to say anything about time because it's not really about time. It's not a contest about doing it in 2 minutes or 3 minutes or 5 minutes. It's about doing it properly. And obviously the outcomes are quite similar to any other golden procedures, as we would call it. I won't dwell too much on this because my colleagues from HelpMeSee will speak about this. Obviously, those of us who were trained once upon a time, we know what it is to deal with the wet lab, the knife is not working anymore, the dog, pig's eye, goat's eye, you cannot cut in it anymore. So a simulator is the ideal case. You can repeat all the steps, all the times that you want. If you're having difficulty doing the tunnel, you can do it 200, 300 times. So that's where you can become proficient and obviously translate those skills to the operating theater. So it's a holistic approach that we're advocating for. It's not just one step. And obviously, we want to help deploy surgeons everywhere, wherever there's a need, and working in conjunction with the partnerships that we're developing, such as that with the International Society of Manual Small Incision Cataract Surgery. And the target audience, well, it's obviously ophthalmologists. In many countries, ophthalmologists just have that title, but they haven't been taught surgery. Ophthalmologists in training to help improve this. And obviously, as we said, we're doing a holistic approach. We have the idea of distance education, particularly in the era of COVID-19, with a lot of things that are based on the web. Also classroom, lab sessions, self-study, the simulator training, assessing that you've acquired those skills, and live mentored surgeries with the partner institutions that we are and will be working with in the future, and the synergistic approaches such as the one that we've developed with ISMSICS. And with that, Parikshit, I don't know if you have slides to introduce ISMSICS as such. I believe you're
This is an ISMSICS seminar, so all the audience is and the speakers are ISMSICS. Dr. Boramani generally always does the introduction, but we are a 15-year-old organization, perhaps one of the first in India, which are exclusively for the promotion of manual small incision cataract surgeons. And we now, ISMSICS has 16 state chapters. It has 12 international chapters. And so far about 11 international events have been conducted. But our main motto remains the same: give good quality eye surgery to everyone, for which, of course, manual small incision surgery is without doubt an uncomparable surgery. But then in all our talks, in our meetings, we always talk about manual small incision, phacoemulsification, all kinds of cataract surgery, because there is so much of cataract blindness and there is so much that we surgeons can do to combat it. And earlier, SICS was thought of just as a fast or economical surgery. But now with recent advances, and we have Dr. Rajiv Rao, Dr. Boramani, Dr. Sahu, who will be speaking on it, Dr. MS Ravindran, that it's not just for the masses, but also the classes. It's a classy surgery, and we can give something like a multifocal implant or a toric implant just by doing a manual small incision surgery. So, well, we'll have more on that later. But today's seminar is basically dedicated to training. And in these corona times, of course, hands-on training has suffered because as it is ophthalmology, OPDs are well running, almost half vacant. People are doing surgeries also with anxiety. And of course, the first to be left out are, of course, our trainee surgeons who feel the brunt. And it is here that simulation and simulator-based training can definitely bridge the gap and can bring in skills to those who need it most. So I would like first ask Professor Namrata Sharma, Secretary of the All India Ophthalmology Society, and the AIOS has also commissioned numerous studies as to how to improve residency training. and also studies as to how to standardize training. So Professor Namrata Sharma from the All India Institute of Medical Sciences, at least in India, Professor Namrata needs no introduction. She is a prolific surgeon, a teacher, I think almost 200 or 300 peer-reviewed publications, and of course the secretary of AIOS. So Professor Namrata Sharma, ma'am.
Thank you, Dr. Parikshit, and I would like to thank the organizers for having me here. It is always a pleasure to come at this platform and present and see the energy levels in this group, which are immense, and they have taken the SIMICS at heights which are not only great heights, not only in India, but also internationally, and that it is really a pleasure to see the way it has gone up. So I would be talking to you about initiatives for the cataract training by All India Ophthalmological Society. And this is something that we were even planning to do much before the COVID era. That was way back in 2017. Because we do know that a lot of our postgraduate students in India do not get adequate training in the actual surgery. So we had planned and we had initiated a lot of programs which we called as FACO Catalyst or Reach Out programs. Of course, these programs were sponsored, and one-day program at the AIOS nominated teaching institutes or DNB center or medical colleges and even private centers who wanted to do it, whether in SICS or FACO emulsification. And it was done in 2017 and 2018 at various places, and there were 100 participants in 5 training programs, and all over India this program spanned. And we took about 20 to 25 participants in this. Each of the places had a wet lab with the FECO machine and also provision for SICS. So this was taken, this we did in 2017 and 2018. Now these are just the glimpses to show, of course, that was not the time of the COVID era, so you can see that social distancing is not there, but it was very useful for the students to learn phaco emulsification, and they did it on goat size in virtual, in simulated circumstances. These are just glimpses to show from the various institutes. So we called it Reach Out training program, just like you have a Reach In and Reach Out in community ophthalmology. This was our Reach Out program because we had planned a Reach In program where we had planned a National Surgical Ophthalmic Skill Development Center at the AIOS headquarters itself. Now, both in SICS and phaco emulsification, we plan to have an elementary course and an advanced course. Elementary course for the postgraduates and the fellows who are just beginning, and advanced course for the upgradation of the skills in phaco emulsification and SICS to graduate to more difficult cases. This is on the top floor of the AIOS headquarter building, and this map was also approved. So we had invited various sponsors for the wet lab design, and we had altogether 6 stations. Initially, we had planned only a surgical center where on these 6 stations, the not only cataract surgeries, but other surgeries could also be taught in wet lab situations. And then later on, we even had made provision for a simulator room where we had proposed to buy a simulator for our trainees, as well as we also had some wet lab areas not only for surgery but also for investigations. So we plan to have some topographers, some OCT machines, etc. So that if a trainee comes, then he or she is able to get trained not only in the surgery itself but also in the diagnostic or the investigative part, which included IOL power calculation also. And we had proposed to have machines like LensStar or IOL Master also in this very area. Now, this was very much taken personally for me, what I wanted to replicate, and then I put forth before the AIOS was what we have at our own center, RP Center Ames, New Delhi, the National Ophthalmic Surgical Skill Development Center, which has been there now for almost 25 years plus. So we do have 6 stations there, and in those 6 stations, the cataract surgeries are taught. And now in the COVID times, we've opened it round the clock. Otherwise, it was opening at 3 p.m. It was opening at 12 noon until 7 p.m. because that is the time the residents were free. And we also had a conference area in that very hall so that before commencing, especially for the people who really want to learn before commencing, we could show them the various steps there. And then they could do the surgeries under supervision. And then also when they went to the actual operation theater, they would get their surgical cases. And these are those discussions which are going on with the residents. The resident would present their cases. And this team is led by Professor Tushar Agarwal, who's a professor at RP Center. And then a review of the cases will be done as to what right or what wrong have you done when you have just begun your cases. So it was a useful exercise for everybody. Now this is just to again show you the same thing. And then we do have a virtual simulator as well, which costs several crores, but again, it's a useful tool for learning surgeries, whether it is cataract surgeries or whether it is retinal surgeries. So this is what was the vision, to simulate a similar thing and make it broaden its horizons at the AIOS headquarters. And we have a very good building. It's a 5-floor building, and we thought we would dedicate 1 floor to this entirely. And then the idea was that we would identify 5 zones in India as per our constitution, and then have these zonal ophthalmic surgical skill development centers in these zones. And there were sponsors who were ready to take this up also, and then also have some satellite centers next to the zonal centers, or in zones which are more populated or which have greater area. We propose to have 2 zones in those areas. So this was the proposal actually, but as of now, what has happened is that the sponsor is ready, the map is ready, but when we were just about to construct, I think this COVID came, so that is just being withheld. Now this is, I think, going to be the next way to for people to learn. And this picture I've taken from the internet. And I think the simulators which are coming up, except for the fact that they are costly, but they're a great tool. And if you take the residents' feedback also, they're a great tool to learn and teach.
1 more minute to go.
Yes. So this is what I took just now, HelpMeSee virtual simulator. And I'm sure we can have a look at this also and see whether, we can have this in our headquarters or in our zonal areas in future. It will be a good tool to have. We also started surgeonars for the first time, where live surgeries were actually relayed by the ophthalmologist from their OR to all the people. And these are, from 8 centers we did the surgeonars, and that was again in those times where COVID was not there. Of course, now it is difficult to do and difficult to organize, but that was the idea, that people who can't come can see the live surgeries, and all the difficult cases, easy cases, all were taken up. The advantage was that the surgeons themselves are very comfortable in their own area, and they don't need to travel. The delegates don't need to travel, and the surgeons are comfortable in their own OR, and they don't need to go and perform at some other place. So that was the whole idea of surgeonars. And of course, in the COVID times, our webinars are continuing, which are related to cataract. We are developing education modules of ophthalmic courses in not only cataract but other surgical techniques, and very soon these would be released both at the basic and the advanced level. So to conclude, I think the virtual teaching will take precedence, the online teaching will take precedence, the simulator teaching will take precedence over all the tools, all the physical training that we have been doing. We'll have to co-share resources for teaching and learning, and maybe the students need to go from one place to the other to learn surgeries, so that they have numbers at places where the numbers are available. And of course, we have to overtake COVID and make up for the time that is lost by the students and the fellows. So thank you very much for your kind attention. And
thank you, Professor Sharma, for the briefing on what AIOS plans to do in these times for training residents in cataract surgery. What we can do is we have a 4-minute discussion. What I wanted to know personally was LV Prasad and Dr. Srikant Sahu is here. What is LV Prasad Eye Institute doing to train residents in this COVID era? So Dr. Sahu, you're on mute, sir.
It has been a very difficult time for all of us, and residents as usual took a back step because the COVID thing. Second, the non-paying the patients who were supposed to be like trained, the number of patients decreased. Third, there was some protocol that in the time of per surgery was also decreased. So the training program took a back stage. So once the things started normalizing back, we had 1 hour completely dedicated for training. So right from beginning, the first we used to train the people who are little more than necessarily comfortable, so that they will not need further training after these things stop down. So and those who have to start from beginning, they were given only couple of steps. So this thing has restarted in the way it should be. The only thing what we did is we dedicated complete training a little. We gave more manpower for training purpose in this phase because they have lost out long in the last 4 to 5 months.
Thank you, Dr. Sahu. We have Dr. Deepak Mishra and Dr. Satanshu Mathur here as well. Sir, do you think there is anything that we could do online for training residents now that people cannot travel? Dr. Deepak Mishra.
Yes, sir. Yes, doctor. Yes, Bachok. We are planning many things. And we will conduct that how to make essentials in the wet lab settings at their own places with the help of goat eye and stand. ISMSICS, everything, since we are also skilled courses for under the All India Ophthalmic Societies, and we are training them on the goat eye or the wax eyes, and very soon we
I think
Deepak has said we are planning to do like we are doing SFTC wet lab in the practical in the conferences. Now we are planning to do SFTC Sajina and not just like Dr. Namita told on the webinar on the net. But for the benefit of the PGs, we'll do operate in some doctors' places by the goat eyes, and we will demonstrate them how to use the goat eye, what we were doing in SFTC in the conferences. Now we are planning to do in SFTC in our own clinics, and the PGs are at their own places. So this is the only option we have got at this time.
Yeah.
ISMSICS have a portal plan. We are now forming the academic committee, and shortly we have done a webinar on training. First step we have done. Now second, third, fourth, like all after the so many steps, we will have a national training strategy. And Namata's have done some homework there, and we will collaborate with them to take it forward.
Surely.
So we will join hands together, and we'll see. And your this thing simulator training will really come handy now that it is complete. Earlier it was not complete, so now it is complete, and we will see that it is integrated properly, and we will discuss with the AIOS how it should be a really foolproof training program.
Thank you, Dr. Sahu. It's small discussion on the perspective of cataract surgery in training in COVID times. I move on to the next speaker. We have Mastering the Capsulorhexis in ISMSICS by Dr. Srikant Kumar Sahu from LV Prasad Eye Institute, Bhubaneswar. Dr. Sahu, over to you. Dr. Sahu, you're on mute, I think. You need to unmute, Dr. Sahu.
need to increase your volume also, because you need to increase the volume of the computer or speaker.
Okay. Am I
Yes.
audible now?
Yes, yes, sir. Please go
Okay.
ahead.
Right. So, just a minute. Okay, let me start. Okay. Is it visible? Slides are visible?
Yes, sir.
Sir, your voice is not coming, sir.
Rexis is ideally round, continuous, well-centered, and overlaps the IOL all around the circumference. The size depends on the size of the nucleus, what we intend to do in SICS. And the best ideal size is smaller than 5.5, because we intend to put a lens which is approximately 5.5. So, and that Rexis should cover the lens all around. We should remember that Rexis need not be as large as the nucleus we intend to remove, because it expands. Once if it is CCC, it expands 1.4 times than what it looks. If you see at the Rexis type, it have evolved from the days of envelope technique, which we used in ECC days, to can opener. Can opener is only done nowadays only if you're in trouble, or maybe first couple of cases to do before you can learn CCC. And CCC is the ideal way to do. And with the age of high-end IOS being implanted, CCC is the only way to go. Apart from that, we have Jepto and Femto, which is also in vogue now. So the instruments what we use is mostly cystitome or a forceps, which is a uterine forceps, or the most commonly used forceps. Cystitome is nothing but a 26 or 27 gauge needle, which we need to learn in the initial cases how to bend it properly. It should be like, if you can see, this should be half of this, and it should be 90-degree bend, and the bend here should be around less than 90 degree, like around 60 degree. So that the force is the way what you want. And which is better? Well, whichever is you are comfortable, you can use it. But most of the people use cystitome. Some people use forceps. The forceps come into handy when we talk of shearing force, which the forceps use. And this comes in handy in intimation cataract, where you do not have a support beneath the capsule. The nucleus is liquefied, so the support isn't good. So there the forceps comes very handy, for which also a couple of videos. So the way the physics based on the cystitome works is on stretching. It stretches flattens the capsule and acts perpendicular to it. Well, if you see, what are the variations? Variation 1, we can use a ACM or a viscoelastic. Here I'm using a viscoelastic. I prefer ACM though. And we can do a direct force. First, you just take a nip and push the capsule. Or else, what the other way to make is, we can see here, form a flap and take the outer edge of the flap, rotate it in such a way that it comes to the size what we want. And the starting position what we see differs for anybody. Some like people, some people started at 6 o'clock, like I mostly start at 6 o'clock, 5 o'clock. Some people do start at 12 o'clock. And here you see again under AC maintainer and using defined blue, what I said. And if you see, it is my style is comfortable is anti-clockwise. Some people do it clockwise. Which way we will do? You have to be consistent in the way what you operate. Okay, the basic principle is puncture. The first puncture should be as central as possible. Scratch. Try not to disturb the cortical matter, because it reflex, disturb the reflex. So you may not be able to see the margins. So try not to disturb the cortical matter as much as possible. Take advantage of the sharp edge of the bevel cystitome to the maximum, so that if you do not do that, the cortex get disturbed to the maximum. Then comes the initial flap. or the flap said, stop 1 mm smaller than the size of what you want. The segmented tearing is the basic principle of segment tearing is grasp as near as the margin, ensure that flap is inverted, and the vector force should be titrated. Whether if the capsule is running away, you need to give a centripetal force. If it is coming in, you need to give a centrifugal force. So that.
Sir, your voice is not coming, Dr. Srikant.
Sir, we lost your audio.
Your audio was lost from last 2 or 3 minutes.
Okay. Am I audible at all or not?
Yeah, now you are audible.
You're audible,
okay.
Sir. Yeah.
Okay. So
Sir, again you lost your audio.
okay. Is it audible now?
Yeah.
Yes.
Yeah, okay.
Okay. I'll try to.
Sir, again lost.
Sir, we have lost your audio again. Can we move on to the next presentation till Dr. Sahu fixes his audio and video presentation? Would that be okay?
Okay. Is it audible now?
Yes. It's not audible now. Dr. Sahu, can we move to the next presentation till you fix your audio and come back to you? Would that be okay? Okay, thank you. So we'll come back to Dr. Sahu's presentation. In the meanwhile, we move to the next presentation, the HelpMeSee Eye Surgery Simulator, the perfect training companion, Dr. Chetan Ahiwale from HelpMeSee Mumbai. Chetan, over to you.
Thanks, Ashish. Let me share my screen. Okay, so at the outset, I would like to thank ISMSICS team for providing us this wonderful platform to talk about the HelpMeSee Eye Surgery Simulator. I'm here to talk about the eye surgery, HelpMeSee Eye Surgery Simulator, and we're going to see whether it can be a perfect training companion. I'm associated with HelpMeSee as a subject matter expert and as an instructor. So as SMEs, we help in developing the simulator, and as instructors, we deliver a course based on simulation. So we all saw how COVID-19 has impacted almost every aspect of our lives, and so has it affected resident training. I see mainly two reasons for this. As our previous speaker said, the sheer number of surgeries has gone down, and now we have less training opportunities available to train the residents. Also, resident surgeries typically take longer duration, so in doing that, we are exposing the OT staff, the surgeon, the resident himself, and the patient to each other, which we don't want. So we have to look at newer modalities of training. We all know that the world is going virtual now. We have virtual conferences, we are having virtual webinar. So it's time to look virtual. So can a virtual reality simulator like the HelpMeSee simulator bridge the gap between the need for training and the limited opportunities that we have? So for answer this question, we need to know what a HelpMeSee simulator is and what are its capabilities. So let's have a look at the HelpMeSee simulator. The HelpMeSee simulator is the only M6 simulator available out there. There is no other simulator which can train you for M6 surgery. It's a high fidelity surgery, fidelity simulator. By high fidelity, we mean that it resembles the real eye very closely. It's a 3D virtual reality simulator, so you can actually have a good stereo opsis center perception on the simulator. You can see the shallowing of the AC, and you are completely aware where your instrument is in the anterior chamber, whether it is close to the cornea or it is close to the lens. So that feature is available with our simulator. It has a very intuitive simulation software, and I'm going to talk more about it in my upcoming slides. What is unique about the HelpMeSee simulator is that it has got tactile feedback. So you can actually feel the tissue. You can touch the sclera and feel the resistance offered by the sclera. You can create a groove, and what you feel with your hands is exactly similar to what you feel in real life surgery. So this is a picture of the HelpMeSee simulator right at the top. As you can see, it's similar to our OT setup. We have a surgical operating stool on one side, and in front of that we have the simulator. Right at the top of the picture, what you see is the microscope. It has got all the features like a real microscope. It has got eyepieces. You can focus using the eyepieces, and then you can adjust the IPD, tilt it up, down, and what you get to see is a virtual eye when you look through those eyepieces. So below this microscope, the rounded structure that you see is the head of the simulator, and we see two empty sockets. We don't see any real eye over there because the virtual image of the eye is created in the microscope. Now close to the head are the two hand pieces, one on the right and one on the left. We'll have a closer look at them in the next slide. But before we go there, on the right side, we see a screen which is a touch screen, and you can actually select all the functionalities using those touch screen. Now this is a closer picture of the hand pieces, right hand piece, left hand piece. The right hand piece looks like a syringe. It has got piston, and we see a black structures over there which we call the wings of the hand pieces. So when you close these wings, whatever instrument you have selected for the hand pieces, that will close. So if you have selected a colibri forceps and you apply pressure on the wings, the forceps is going to close. You will see that in some of the simulator videos in the next slides. Now this is a picture of the adjacent screen, which I said is a touch screen, and you can actually control the entire simulation of the simulator using this touch screen. As you can see here, a capsulorhexis with a variable left eye is being performed, and there's a cystotome in the anterior chamber, and the left hand has a colibri. Now you can see some tabs at the top. There is a left hand, right hand tab where you can go there, and there's a drop down menu. You will get to see all the instruments, and you can make a selection of whichever instrument you want for that particular step. There are training tools to train the trainee, and we'll talk more about them. The red tab that you see is for ending that attempt, and once you end that attempt, the performance report tab becomes live, and you can have the report of every performance recorded and graded. So for the sake of simplicity, we have divided the SICS procedure into 4 steps or modules, as we call them. Each module is for a group of steps. As you can see, module A is for tunnel construction, module B for rhexis, hydrodissection, nucleus delivery, C is for cortical aspiration and IL implantation, and the last one is to physiological conditions by hydrating the paracentesis. Now, having these steps divided into modules gives us a lot of flexibility, and we can actually customize this program of certain steps as per the requirement of an institute or an individual. So you can just give a capsulorhexis module to any particular individual institute where they want to want the trainees to learn capsulorhexis on a simulator. So let's look at a simulator video of tunnel construction. Here you can see in the left hand we have a colibri forceps, and in the right hand we have the crescent, and a groove is being made. Now the resistance that is felt on the right hand is exactly similar, as I said, to real life surgery. Now we are cutting and dissecting a tunnel. So the visual cues are rich, and like for example, to know how deep your blade is within the sclera, you can just look at the visuals, and you will come to know if it is superficial, it will be seen more clearly, and if it is deep, it will not be seen so clearly. So it resembles exactly like live surgery. Now there are certain training tools. As I said, we can see there is a IOP bar on the left side, and you can see that it is turning red or green at on some occasions. That is because the trainee is having a lot of pressure on the eyeball. Here's another training tool in the form of the angle of the stab blade. You can see if it is in the normal range, it will be seen as green. But if you lower it or if you hold it too vertical, then it will be out of that range. So we make use of these training tools so that trainee knows exactly what should be the angle of approach to the eye while making a paracentesis. There are also other things like guidelines. As you can see, there is a green line which outlines the inner tunnel opening, and one has to make a cut on that line. So that guides the trainee where he should make the cut. Now this is another model of capsulorhexis in progress. You can see that the capsule is stained with trypan blue, and we're using a cystotome here to create a flap and then make a rhexis out of it. So the first incision is made, and then a flap is lifted, and then the trainee has to progress the flap in order to get a desired capsulorhexis tear. So the trainee gets to learn how to direct the flap well, how to have a good sized rhexis. Now again, here we have a training tool which indicates the tunnel opening, how much is the tunnel because of the cystotome. If a lot of pressure is being applied on the inner wall, it causes viscoegress and sharding of feces. So those kind of things are taken care of in the simulator. Now a trainee might end up making a complication. Like here you can see, if he goes too much to the periphery, he's going to end up having a tear run out, and that gets reflected in the form of alerts on the screen. So, and the instruments turn red. Now every performance gets captured in what we call as performance data. And here you can see we get all the information about the attempt, like how big the capsulorhexis was, whether there was a contact with the eyes from the cystotome, or whether there was an endothelial touch. And at the end, we get a summative assessment, like whether it was an unsatisfactory attempt or a satisfactory attempt. Similarly, for hydrodissection here, I think the training objective is to for the trainee to know where to place the cystotome, the hydrodissection cannula, in order to inject saline, and what amount of fluid should be injected in order to get the nucleus edge out. Now, once we have the nucleus edge out, we have to dial it out into the anterior chamber. So we use a Sinski hook, and you can see how it is being used to tire the nucleus out or tire the nucleus out. Now, a trainee may be a little less careful by performing this step, and if he pushes the nucleus around, it is going to cause stress on zonules and zonular breakage. So even that gets reported in the form of percentages as zonular breakage. Now, as I said, every attempt gets recorded in the performance video, and we get a detailed information about how well the attempt was done. So here we see zonular breakage more than 50% was done, and therefore this attempt has been reported as unsatisfactory. Going to the next step of nucleus delivery, here we use a vectis to get the nucleus out. Now the resistance offered by the tunnel for pulling out is equal to what one feels while delivering a nucleus out in a live surgery. On the right hand side view, we can see how those instruments are held and manipulated while working inside the eye. Now here we see a cortex removal being done using the Simcoe cannula. We can see how the Simcoe cannula moves in all directions and aspirates the cortex by setting it to the center. There is a training tool at top which denotes the position of the tip of the Simcoe cannula with respect to the capsule. So when the trainee is behind the iris, the only visual cue that he has is he can look at the training tool and see whether the tip is positioned inside the capsule. So when the trainee achieves competency, we withdraw these training tools, and then they just have to do it without a training tool, and they have to do it correctly. Now this is a IL insertion. We can see a PMMA non-foldable IL is being held with McPherson forceps, and then the trainee and inserts this IL into the anterior chamber and then into the capsule. What we see at the top at 6 o'clock position is again a training tool which where the leading haptic is with respect to the capsule. So it is within the capsular bag, it is shown as a red dot which lies within the capsular bag. Once we have inserted it, we have to dial it into the bag, and for that we use a Sinski loop. The training objective here is that for the trainee to learn how to dial it and at the same time also push it downwards towards the capsule as he dials it into the bag. So those were the steps of M6 surgery that we have simulated, and you can see that it's a complete package with all important steps covered, and the trainee gets to do as many as he wants to do on those tasks, and can work on it until the time they become. We have a very structured course which we call as MSTC, which is a M6 simulation based training course. It is a 8-day course where we take the trainees through simulation based sessions. We also have other training resources like the ebook On the right side in the center, what you see is the ebook screenshot which has all the animations. It has detailed explanation of all steps of surgery. Then there are pictures and real surgery videos. Then we take them through the classroom where we talk about all the steps in detail, and those are interactive sessions. And after that, what we do is take them to the lab activities where they get introduced to real instruments. They work a little bit on certain props like balloons or tomatoes, and they just to get a feel of how a real instrument, how heavy it is, and how it should be held. Then a maximum time during the course is spent on the simulators to learn all the steps that we saw in the slides, and once they are competent, they are declared as certified for the course. So this is a unique course of its kind we conduct here in our Mumbai center. And I welcome all of you to Mumbai to witness this unique simulation-based training course for SI6. Thank you.
Thank you, Chetan, for the wonderful introduction to our audience about what the capabilities of HelpMeSee small incision cataract surgery training simulator and the curriculum associated with it.
Ashi, I will take 30 seconds only.
Yes, Dr. Mathur.
Chetan, it is a wonderful job you and your team and HelpMeSee have done in 1.5 years. Because what we have seen in the last year in surgical training area with us, we were having 50% of this. You have done a remarkable job in teaching, because the thing that you are having in the marker, your alarm system, that where the PG is going, participant is going wrong, is a wonderful job. We congratulate you. It is a really going to be very big help for all of us in teaching and for the learning. Thank you.
Thank you, Dr. Mathur. I would like to also ask Dr. Shri Krishnamurthy from Shankar Netralaya. A few years back, I think we did a study where Shankar Netralaya was also one of our partners. So we randomized students, and after simulation-based training, they went back to their institute to continue with the training. So Dr. Krishnamurthy, would you like to tell the audience about the experience that you had?
HelpMeSee simulator is actually very good in the sense that the candidates were they got a lot of confidence as to how to handle instruments, and the tactile feedback, like you were telling, is very useful for them to know where they are with the tissues, whereas in some of the other virtual reality simulators, we don't have much of a tactile feedback coming in for the candidates. Because when they did the training, it was only the tunnel construction that was going on. So even when they came back to the base and did the surgery on the human eye, the number of complications or other premature entries or buttonholings that they had with the human eye was lesser for those who had already done on the simulator when compared to the others who were directly doing on the human eye. So it's an excellent tool, and I can find that it has evolved into the entire cataract surgery module.
Thank you, ma'am. We'll be showing you the rest of the software as well. Interestingly, I heard Professor Sharma, Namrata Sharma, talking about having a simulator for the AIOS Reach Out one-day program. Ma'am, can you tell us the details of that simulator, or where does HelpMeSee M6 simulator fit in those programs when you say about the zonal teams that you will be doing for remote training?
So what we had planned was, we had planned to have a simulator at the AIOS headquarters itself, one simulator. And we had planned to have, because we know that on the simulator you can do a lot more surgeries apart from cataract. And we had also planned to have these, if the plan goes by, simulators even in the zonal centers, which we could, identify. Maybe we could take government hospitals, so we could take in a private, sectors as well in the various zones. So that was the plan, but I'm sure it will materialize as the, in fact, we would have been happier if it had materialized earlier, then maybe we could have used it now. But I'm sure it will materialize in the future.
Sure. Thanks, ma'am. Thank you. We move on to the presentation.
Ashish, can I just add a quick question?
Yes,
Dr.
please. Srinivas, yes.
Dr. Chetan, very good presentation. I just wanted to know from you and Ashish that how reproducible is this technique? Can all the institutes afford it, or can the individual practitioner can afford it to train the SICS trainees?
Srinivas, HelpMeSee being a training organization, by you asking, is it affordable? We don't plan to sell the simulator to you or anybody who asks for it, but we intend to sell the training around it.
Because we need to do this all on the simulator itself. So how reproducible is it across India? Say, for example, if the person from South wants to do, or person from to Mumbai, or where your affiliated centers to do it, or how is it?
Yes, so far we had the same model, Srinivas, that people used to travel to Mumbai center and learn it here. We are also working on a remote capability wherein we can remotely train students who have a simulator access to them. We did a pilot with this in the past 2 weeks time, where we trained surgeons from across continents, across time zones, people from America, and next week we'll do with China because they already have the simulator. Having said that, if COVID continues, we would send the simulator, say, to you or someone else in Chennai for a specific time period, and we are having remote training capability, so that helps solve the problem, considering not everybody can travel to Mumbai.
Okay, can you make it affordable so that many centers can have it?
Yes, it is for in the long term. It is for serving the needy people and training people faster and removing the cataract backlog. And yes, HelpMeSee has that in mind.
Okay, great. Thank you.
Dr. Boramani, I have one quick question.
Yes,
is the machine ambidextrous? Is it conversant with both the right-handed surgeon as well as left-handed surgeon, or it presently only works for right-handed surgeon?
Presently, 90% of the time it works for the right-handed, but you get left-handed trainees, Dr. Boramani, to be very frank with you. And we have our own tricks and tips to tell them, and they work well. Right. We move on to the presentation of Dr. Sri Kumar Sahu sir, which was incomplete because I'm sorry, Shrikant Kumar Sahu sir, which was incomplete because of audio incapabilities, and they have sorted that out. Dr. Sahu sir, over to you.
Yeah, am I audible now?
Yes, sir. Please go ahead.
Okay. So coming back, just a minute. Something is going bad. Just a minute. Now the video is gone back. Like, what do you call it? Okay. Okay, let me go to this video now first, then we'll come back. Now we go to this kind of scenario every day. If you see, like most of the time, it's intimacy cataract goes, this is called an Argentine flag, and sometimes it happens spontaneously. Sometimes even because while we are managing, it opens up very slowly, but then we are not able to control it. So the way to go is use a high dispersive viscoelastic and be careful not to go to the sliding part of the lens. If you go to the anatomy lens, there is a cap tabletop and then it slides down. Once you reach into a sliding down part of the downhill of the lens, then the chances of it extends very high. As you see in this case, as it was in center one control, the moment it went to side, it just goes out. And the force what we use is towards the center, so that and going as near as possible to the capsular margin. So that prevents it from becoming a runaway rhexis, and we can do. Now suppose if the runaway rhexis has also happened, what we can do is we can cut the excess edges and make the rhexis complete. And in these cases, SICs also do. Now, this is what I was saying. The lens is flat here; it is sliding down, and more so in intermittent cataract. When you flatten this further, this part becomes more pressure becomes more here. So that is why we need to take out all of the cortical matter. So this is one way. You take out with a needle, first puncture with the needle, take out some amount of cortical matter, loose, and some pressure is released. Make a small incision, very small incision, which is again on the tabletop of the nucleus. Once it is completed, you can take out, loosen up all the pressure from the lens by taking out with a single port cannula or with a simple, and then once you take it out, the pressure goes down. And here again, to point out, the cystodome may not help because the pressure underneath it is not there. So here the cystodome forceps comes in handy, whether a micro forceps or a rotator forceps. Anyway, a forceps is needed here to make the complete rhexis, as in this case. Now, if you cannot make a small rhexis, just a small puncture sometimes, and immediately pushing out the cortical matter from this side also helps in relieving pressure, so that we can make the rhexis comfortable after that. Again, to note, here we are using a rotator forceps from the main node. This is another technique which I haven't used much, making a small pinhole with a rhexis with a phaco handpiece. So if you see that, and we go to another use of micro, now using this case, the rhexis has run away and it has got stuck in probably in the jonules. If you go far off, it was to get stuck in the jonules. So here, if you see, I'm trying to take it out with the cystodome, it doesn't come in because the force is shear is just parallel to it. So here the role of a shearing force with a micro forceps helps to pull it toward the center, so that these couple of journals get broken, but then it comes back to center and you can comfortably continue the surgery thereafter. Okay, this is another technique, the onion peel technique. This is more common in our scenarios where the underdeveloped country, people come with mature intimation cataracts. So here we try to make a small rhexis. If you see that it does not extend, go slowly and steadily as far as possible, and by layer, what we call onion peel. Whenever you see that the support is not there, the role of microcystodome, the micro forceps is invaluable. It helps it to take it out in such a way, and the force has to be adjusted in such a way that it does not go out, neither forms a very small rhexis. And we can do a complete cataract surgery with this amount of the size of the rhexis. Now, most of the time, sometimes we see the nucleus size is much larger, the pupil size is small. We can do the rhexis by giving mind you, this is not a blind procedure. We can see the margin of the rhexis after the staining with a different glue. Here I would repeat, the valuability of staining with different glue helps you to convert the complete rhexis underneath the pupil, which you cannot see. So in summary, CCC is ideal. Continuous curvature capsule rhexis is ideal. Circular is ideal, but circular may not be always possible. But continuous curvature is needed. Use dye appropriately. Learn to learn all possible techniques, but follow one technique. Like whether you want to do under AC maintainer or viscoelastic, what should be the starting procedure, whether you want to do with clockwise or anti-clockwise movement. Learn all technique, but follow one technique which you are comfortable. When the capsule does not obey you, look for the cause. The cause can be a shallow AC, because of positive pressure. It can be a wrong instrumentation, or maybe the patient is just training bad manner. So talk to the patient. So look for the cause why the capsule is not obeying you, or a simple procedure like filling in the AC also helps you to get the capsule back in position. Once you see it is going out, change course of direction. The vector should change so that it comes towards the way you want. In such a special situation like intimation cataract, when the pupil is small, it needs specific modification and skill set, which comes with time. But then one thing for sure, if for small incision cataract surgery, even if the control is not there, canopy is still also option. But yes, we cannot put the premium IOL, or we are not very sure whether we are putting the IOL in the bag or not. So that is why learning a CCC, good CCC, helps you in all situations to get a good outcome for the cataract surgery. Thank you. And sorry for all the disturbances.
Thank you, Dr. Sahu. Technical glitches are not in our hands, but it was a wonderful presentation giving glimpses of how to do a capsulorhexis, especially for trainees who find it very difficult to do rhexis in intumescent cataracts. I would like to ask Dr. Neeta Shanbag from D.Y. Patil Medical College, Navi Mumbai. She is a professor and trains a lot of residents in capsulorhexis in MSICS. I want to understand does she employ any technique differently for doing capsulorhexis in intumescent cataracts? Dr. Shanbag.
Thank you, Ashish, for inviting me. And I usually train my residents with an AC maintainer because it leaves the anterior convex surface little flatter and it is easier for them. Then with the same cystitome, I allow them to aspirate the intumescent stuff and don't allow them to proceed with the flap till they have removed some amount of tension within the lenticular substance. And after that, if I can allow them to take the support of the nucleus below and continue with the rhexis, fair enough. Otherwise, they can use the capsulorhexis forceps to do it.
Thank you, Dr. Shanbag. Anything that you do differently at EMOVAN to train residents, especially during rhexis in intumescent cataracts?
Not really. I mean, we use a very standard technique. We never use anterior chamber maintainer. For us, it just adds another step, and I know that's something that most of our training surgeons don't like. So essentially, it is what you just mentioned.
If I may add a point.
Yes, ma'am.
A couple of the beautiful videos, Dr. Shrikant. A couple of things for the novice surgeon who's watching the video, that he kept the flap always flat. And when you're folding the flap over, it will be a mirror image of what you're planning to raise. And the flap mentally is actually, the radius of the flap is actually the radius of the circle of the rhexis that you're actually planning. So if the flap is always flat and the flap is a mirror image of what you're finished raising, the immediate 2 clock hours, then you'll find that the rhexis, as you move it around, continues to form the same circle that you're originally planning to do. And two important things that for him it is reflex, but for the novice surgeon to watch are the cystitome was using the side port as a fulcrum of movement. So whenever he was going towards the superior half, the handle, the hub of the cystitome was moving inferiorly, and when the cystitome was moving towards 6 o'clock, the hub of the syringe will be somewhere superior. So the side port has to be used as a hub, as the fulcrum of movement. And similarly, when he wants to puncture the center, the hand is lifting up. So it's like a bird pecking. That's what I tell my students. So when the bird is pecking, it's actually the other end that lifts up. So like that, when the cystitome tip punctures the capsule, the hand should lift up so that there is no pressure on the side port. Because the pressure on the side port for the trainee is one of the commonest reasons why the anterior chamber shallows and the visco comes out, and they have to repeatedly keep injecting visco. Once you have mastered the side port movement, you will find that you are able to do the capsulotomy without even injecting visco even once extra. What you have filled, you will be able to complete the entire rhexis without repeating a viscoelastic injection. Thank you.
Thank you, Dr. Krishnamurthy. Thank you, Dr. Shanbag. I got a new word, bird pecking, today. Thank you very much. We move on to the next presentation. We have been hearing about aerosols in phaco. People are scared to do surgery. We have small OTs, and what about the aerosol coming out? Dr. Rajesh Vedachalam from Arvind Eye Hospital take us through what happens in SICS and how do we tackle aerosols that come out of it. So Dr. Rajesh Vedachalam, over to you.
Thank you. Good evening, everyone. So we'll be seeing the aerosol reduction in manual small incision cataract surgery. Because of COVID-19, the world has come to a standstill, and the amount of surgery V2 has also come down a lot. COVID mainly transmits via two methods. One is touch, either direct or indirect touch, and aerosols and micro droplets generated by coughing, sneezing, talking, and it may be also generated while operating. And most of our surgeons are afraid about these aerosols. What is an aerosol? Aerosol are micro droplets which may carry the virus particle. The most commonly done ophthalmic surgeries are phacoemulsification, and the second most commonly done surgery is the manual small incision cataract surgery, which is done mostly in the developing world. For phacoemulsification, there are a lot of recommendations by Bristol Eye Hospitals and Narayana Nethralaya. In Bristol Eye Hospital, they recommend using povidone reduces virus load on the conjunctiva, performing irrigation aspiration for a minimum of 6 seconds prior to starting active phacoemulsification. A smaller wound size reduces visible aerosol, and HPMC application in the wound site during phacoemulsification decreases aerosol production. And Narayana Nethralaya has proved that very minimal or no aerosols are generated during phacoemulsification, and they recommend other precautions such as using povidone goggles and PPE to prevent and protect ourselves from COVID. But what about in manual small incision cataract surgery? Are aerosols generated in manual small incision cataract surgery? And if they are generated, is the infectivity of these aerosols more or less than the aerosols produced in phaco? As you can see, during the construction of a tunnel, there is minimal bleeding, which can be a definitive source of the virus. So the aerosol generated during SICS is more infective, and we should make sure that we do appropriate pottery and minimize the bleeding as much as possible. So during lockdown, we did a lot of experiments using goats. We used slow motion video recording with a focus beam and a dark background to capture the aerosols and the micro droplets generated in different steps of SICS. Does jetting saline over the cornea generate aerosol? So jetting saline is the most common step which is used in almost all the surgeries. As you can see here, jetting saline produces aerosol, and it produces significant aerosol when it comes to irregular surfaces such as tunnel or corneoscleral junction. This can be minimized by removing the cannula and gently flushing the saline directly without the cannula. If there is bleeding, we can use a cotton to mop the bleeding instead of jetting saline. While spraying saline from the irrigating victus generator aerosol, a lot of us have the habit of checking the patency of the irrigating victus by spraying saline over the eye. As you can see here, it generates significant aerosol. We should check the patency only in the drainage bag, and also while flushing, it should be flushed gently to avoid aerosol generation. The use of Simcoe cannula generates aerosol. We usually approach the eye with the Simcoe cannula on. The irrigating fluid, the jet which is produced by this cannula, when hitting irregular surfaces, can generate minimal aerosol. So to avoid this, we should always have the flow off and enter the eye and switch on the flow of the cannula. And before coming out, stop the flow and then come outside the eye. Are aerosols created by flushing out the Simcoe cannula? Most of us flush out outside the eye when there is a block. Here you can see minimal amount of aerosols are generated. If when you're aspirating, if the cannula is full or the syringe is full, sometimes we flush it out without removing the cannula. This may also cause significant aerosol. Here you can see if it is blocked, try to flush out the cortex inside the eye and not outside. And if the syringe is full, then remove the cannula and then gently flush it into the bag. Don't flush it out with the Simcoe cannula. Will hydrating the side port cause aerosol? As you can see here, side port hydration causes minimal aerosol. This can be minimized by using HPMC over the side port before hydrating it. and to place the cannula in the right position and then start hydrating the site and stop the hydration before coming out of the site. So finally, we recommend that gently flushing over the cornea without the cannula for wetting it. Check the patency of the irrigating vectors directly into the drainage bag. Open the irrigation of Simcoe cannula only after entering the anterior chamber and turn off the irrigation before exiting the anterior chamber. Detach the Simcoe cannula and gently flush out the aspirated fluid directly into the drainage bag. Use viscoelastics over the side port before hydration and stop the hydration before bringing the cannula out. And even during cauterization of the conjunctiva, the final procedure, it is better to do it right to prevent splashing of saline. So I hope all of us follow all these precautions and reduce aerosol as much as possible and do a safe surgery. Intelligence and capability are not enough. There must be the joy of doing something beautiful. Thank you. I thank everyone for giving me this wonderful opportunity.
Thank you, Dr. Rajesh Vedachalam, for this wonderful perspective on reducing aerosol in SICS surgery. I would like to ask Dr. Barun Kumar Nayak about his perspective and what he thinks can be done to reduce aerosol in SICS surgery. Dr. Nayak.
Thank you, Dr. Ashish. Am I audible?
Yes, sir. Please go ahead.
Yeah. So thank you, Dr. Ashish. And it's really sometimes you listen and sometimes you don't really realize that these simple procedures also can generate aerosol so much, because we all were concentrating only on while phaco is turned on, and we're concentrating mainly on the phaco. But today, whatever I heard, it was really eye-opener. And whatever the simple precautions that he had said is really, I think nothing is difficult to follow, and all this is so appreciated, and he has shown it so nicely that I'm really impressed with his presentation. So it's a fantastic, well done.
Thank you, Dr. Nayak, for your perspective on aerosol reduction. With that, we move on to the next talk, which is from the keynote speaker, Professor Anne-Sophia Thompson from Copenhagen Academy for Medical Education and Simulation Development from Denmark. She does a lot of research work on simulators, and we have seen so many papers published on the great work done by Professor Thompson. So over to you, Dr. Anne-Sophia Thompson.
Yes, thank you. I just need to go back. Thank you very much for the introduction. And first, I would like to thank the organizing committee for inviting me to have this talk on this very important topic. It is very inspiring to hear all of you talk about the importance of simulation-based training. My name is Anne-Sophia Thompson. I'm an ophthalmologist associated with the eye department in Copenhagen, and also Copenhagen Academy for Medical Education and Simulation. Shortly about my background, as you already mentioned, I've completed a PhD in the assessment and training of complex technical skills, more specifically in cataract and vitreoretinal surgery. And I'm continuously doing research on this topic. I have no financial disclosures relevant for this talk, and currently I'm collaborating with HelpMeSee. So the title or the question of my talk is, does cataract training on a simulator work? And the short answer to that is yes, it works. Some years ago, we completed a study investigating the effect of standardized training on a virtual reality cataract simulator for phaco emulsification, and found that surgery improved by 32 and 38%. So the 32% was for the novice group and 38% for the group of intermediate surgeons. We use the participants as their own controls by comparing their performance before and after training, and we took the natural learning curve into account. So what we found in this prospective study is that simulation training has a significant effect on cataract surgical skills in the OR. Other studies have shown a significant reduction in complication rates after implementation of virtual reality simulation training. Ferris and colleagues, they found that there was the percentage of posterior capsule rupture was reduced by 38%. So that is very significant change. So it really works, and this is a study by Ferris and colleagues. So it really works, and there are several studies confirming these results. So what is evident is that we move the learning curve from the patient to a simulated setting. Here you see a graph showing the percentage of PCRs correlated to number of surgeries performed on the x-axis. And less experience, which is the left side of the graph, is correlated to a higher complication rate. And as you progress along this curve, you experience less complications. So we really have the potential to bypass this first part of the learning curve on patients. So simulation training works. How do we ensure the relevant application? There are actually a few examples of non-significance when looking at complication rates after the implementation of simulation-based curricula. So what makes the difference? What makes it work? And the first part is about implementation. Should it be implemented by random use, unsupervised trainees? Should it be a fixed schedule program or time fixed, which is the traditional way of training surgical skills? Or should it be the concept of mastery learning? Mastery learning is a concept where the trainee, they train until a predefined benchmark or competency level before moving to the next part of the training program, which may be the supervised practice on patients. This is an example of how individual learning curves might look like. If we use the traditional method, that is a time-fixed program, then after, for example, 2 hours of training, the trainees, may have a very heterogeneous level of competence or skills, as you can see by this marked line. When applying mastery learning, we set a benchmark, and by that we ensure that trainees reach the same level of competence. So we know from previous review and meta-analysis that simulation-based mastery learning is associated with large benefit on skills with an effect size of 1.17, which is very large. So just to compare, then longer training has an effect size of 0.34. So mastery learning makes a huge difference for your training outcome. Various instructional design features have shown to have significant effect on skill acquisition and patient outcomes. In the favor of time, I will not get into further details, but again, you can see from this meta-analysis that mastery learning favors the acquisition of skills and better patient outcomes. So mastery learning is of high importance when applying simulation-based training. It will ensure a much higher and more uniform skill level among trainees. To implement the concept of mastery learning, it requires metrics that may be either computer generated, which includes motion tracking, or rater or mentor feedback or assessment. These metrics should show evidence of validity, which is a whole other talk, so I'll not get into further details about that. Just underline that there are very specific requirements. There are different categories of metrics, and there are a huge difference in workload, risk of bias, and correlation to actual surgical skills. So these marked here is the radar assessment tools, and they have a very high workload, a fairly bit of risk of bias, and they correlate very well to actual skills. Then we know that self-evaluation is not useful. And then we have the computer-generated metrics. Then they're very beneficial when looking at workload. They entails a very limited risk of bias, and they have also shown to correlate very well to actual skills. So this was about the instructional design, and more specifically about the concept of mastery learning. Another dangerous pitfall that may cause non-efficient training or worse patient outcomes is negative transfer. And negative transfer is when previous experience interfere with the acquisition of new skills. So what we know is the training of surgical skills, or at least complex technical surgical skills, they're probably very procedure specific. We did a study investigating the effect of prior cataract surgical training on the acquisition of vitreoretinal skills. And we randomized participants to either pre-training cataract surgery to proficiency or no intervention. And then all participants completed vitreoretinal training until benchmark level. And what we found was that the group of cataract trainees, which is the triangles in this diagram, took longer to reach proficiency in these new procedures. So our results showed a trend towards negative transfer from cataract to vitreoretinal surgery. There are only very few studies investigating this aspect of training, but there are a few studies in endoscopic surgery simulation that have shown that a direct view of surgery during training has a negative impact on skills when they are completing surgery using endoscopic view afterwards. But we need more evidence on this specific aspect. So the conclusions from the presented findings are that simulation training has significant effects on performance scores and patient outcomes, and that it should be implemented in an evidence-based manner using mastery learning, and that the training should be procedure specific. So these findings and the use of simulation-based training have significant implications for global blindness. As you all know, a huge amount of people are suffering from visual impairment or blindness due to cataract, and surgery is the only cure. As you see in this world map, where the yellow and green colors represent a low cataract surgical rate, there are areas where the access to cataract surgery is severely limited. As you're also aware, in these countries, the ISMSICS procedure is more favorable to phagoemulsification due to the low cost, similar outcomes, and similar complication rates. So this is where the HelpMeSee simulator comes into the picture. And it will be very interesting, and we are very eager to see the future developments in the use of virtual reality simulation and global eye health when applying this new training tool. So thank you for listening.
Thank you, Dr. Thompson, for giving this overview on how simulation and simulation-based training is helping people learn better, how it is helping professors train better. I would like to have a comment from Dr. Karan Bhatia. Dr. Bhatia, what do you think about this training on a simulator perspective? Dr. Bhatia.
Thank you, Dr. Bachav. Dr. Thompson had a beautiful talk showing some wonderful data. Simulator training is the way to go now, particularly with the impact of COVID-19 on training that has also been emphasized by the previous speakers. Not only that, we need to, I feel there should be like the Oscar grading scheme that has been given by the ICO to evaluate residents in surgical training. If we have some sort of a scheme while in simulator training also, I think that would be very beneficial. But yes, it is a way to go forward.
Thank you, Dr. Bhatia. With that, we move on to the next presentation. It is going to be micro-incision topo-guided manual small incision cataract surgery by Dr. Amulya. Dr. Amulya Sahu.
Yes.
Dr. Sahu, it's your talk now. Micro-incision topo-guided MSICS. Please go ahead.
See this 2mm MSICS, it was a challenge when I started it because the phaco's prominence was a small incision. So when we are establishing the platform for the MSICS, I thought whether we can do a 2mm or not. Then in 2005, I demonstrated 3mm MSICS. Now recently, last year in All India Institute, I demonstrated 2mm MSICS. Now the advantage of this thing is that if there is no astigmatism, then you are not contributing to astigmatism when you are doing this surgery. Now if there, it can reduce the astigmatism up to 0.75 to 1 cylinder. And extra advantage what I'm getting, I'm putting a lot of multifocal IOL and getting excellent results. If I do the first eye, the patient easily come for the next eye for multifocal and toric. So there is an incentive for doing this thing. The flip side is that it requires a lot of mastery over your medium. And as you know that we start with 5.5 and 6mm SICS, which is standard. But to come to 2mm, you must have the skill and expertise, plus the modification of instruments which I have done. It is a must for this, because whatever instruments are available now in the market will not give you this advantage of doing the surgery because they are big instruments. So I have been very happy, and then the only thing people will say that the endothelium will get, the fear side is that the endothelium will get compromised. I have done a lot of study with a Conan specular microscope. I have seen that it is hardly any change in this endothelium if you know how to do the surgery. The nucleus, what I do, if it is very soft, then I try to break it in the tunnel, or if it is little grade 3, grade 4, then I divide the nucleus. And in division, what I do, I have done this viscoelastic cannula, which is available. I compress it in the front, so it becomes little flatter. So I put the vectis, my modified vectis, below the lens, and go on infusing visco above the lens, and at the same time press it down and break it to as many pieces as I want. And then it can be brought out easily. So this is a few trends which are now India, we are advancing. One is the mine 2mm, and then the wound modulation which Boramani is doing, then he is giving astigmatic free. And now Rajiv is going to make a gift of this computer guided MSICS, which is bifocality in monofocal IOL. So then this is that was in the this I usually cut the conjunctiva and tenon separately, and then after the surgery, and this is a 1.5mm behind the limbus, and give the two back cuts. This is erasing the, I don't do the cautery, it is erasing.
The lens has to be implanted without injector. If lens has to be injected with injector, there is no factor. Side reports are given. On that, the right side. Hexis is done.
So I'm stabilizing with the dialer.
Tunnel is extended into the substance of the cornea. Remove side. Another self-sealing incision is done to enter the AC. Lens is mobilized into the AC by running with my modified diagram. Lens is brought out with modified practice. Totally and the tunnel. Remaining pointed end is mobilized was the tunnel and taken out. Protects training by from 25 44 by input cannula. Lens policy that lens is insert mobilizing through the level pocket. Lens is dilated from the side pocket. Side pocket are injected and injector is button.
Thank you.
Thank you, Dr. Sahu, for this wonderful video demonstration of micro-incision topo-guided MSICS surgery. I would pass it on to Dr. Parikshit Gupte for comment and your perspective on MSICS micro-incision surgery. Dr. Parikshit. You're on mute, Dr.
Unmute.
What is muted?
Rashid, one question to Dr. Sahu, sir.
Yes, please.
It is always pleasure, sir, a treat to watch your surgery, but 2 millimeter we have seen it so many times. Sir, if we are given 2 millimeter incision, why you are not implanting the lens with the injector?
Hey, injector I do, but I have made the pocket here just to show you. In case you don't want to inject, you can take the advantage of the pocket to mobilize the lens inside. It is just one more technique. I do most of the time injecting, but this is just to say those who don't want to, there is a facility available with us which microsurgeons don't have.
Okay, thank you, sir.
Dr. Gupte, your comment, please. You're still not audible, Dr. Gupte. I think we are not able to hear Dr. Gupte. Next presentation, SICS, a better way to tackle astigmatism by Dr. Jagannath Boramani. Dr. Boramani, over to you.
Arshid, you check your audio.
Yeah, can you hear me? Hello?
Yes, we can hear you. Please go ahead.
You can, yeah. First of all, let me thank Van and his entire team of HMS, Mr. Ashish, Chetan, Akshay, for organizing this joint webinar. Now I am going to show how SICS can be a better way to tackle the astigmatism. Scleral incisions are very secure incisions. They heal very well and they are forgiving in types of incisions, because if little bit of raggedness here and there, even the stretching on the incisions doesn't matter much vis-a-vis corneal incisions.
Excuse me, sir. Sir,
yes?
We are unable to see your presentation.
Oh.
Sir, request to please stop share, sir.
Yeah, I'll stop share and share it again.
Yeah, share screen and then click on first option, sir, screen.
Yeah.
Yeah, click on first option screen. Yeah.
Can you see now?
No, sir. Yeah, double click on that, sir.
Yeah.
Open your presentation.
You can see now?
No, sir. We are unable to see your presentation. Where is your presentation, sir?
No, it is on the, I can see it, but here I have seen the message, your screen sharing is paused.
No, sir, minimize this.
Yeah, 1 second. I'll stop sharing again.
Yeah. Click on share screen, then
click on the share screen.
Yeah, click on first option, sir, screen. When you click on share screen, then first option is screen, sir. Click on that. Then click on share button, blue color button.
Yeah, I have selected the file and share. Can you see my screen now?
No, don't select the file, sir. I'm saying don't select the file.
Okay.
When you click on share screen button, then a window will pop up. In that window, first option, select the first option is screen.
See, first I click the share screen.
Then click on first option is screen. Basic के नीचे sir एक first option is screen.
No, it is not screen. Optimize screen for sharing video, share computer screen.
Sir ऊपर कह रहा हूँ ऊपर.
Screen.
Back to Dr. Boramani.
Yeah, screen I clicked. Yeah, correct.
Screen पे click करके तब share कीजिए sir.
Now?
Yeah, now it's visible, sir.
Yes. So you stop me after, just remind me after 5 minutes. What is the advantage of phacoemulsification over SICS? Because it is said that it induces less astigmatism, and this is a major advantage of phacoemulsification over SICS. So many phacosurgeons, their astigmatism is almost less than 0.5 diopters. But is it advantageous? Because you get different types of patients with different types of astigmatism. So every time having only 2.2 mm clear corneal incisions may not be an answer. It may not control the astigmatism properly. You should have some methodology wherein you want to induce or neutralize more astigmatism. You should be able to do that. At the same time, if you don't want to induce any astigmatism, you should not be able to induce the astigmatism. Now, this principle of incision funnel is well known. So why we take the curved incision, the prawn or curved incisions are to remain as much as possible in the funnel so that the astigmatism induced is minimal. Now you imagine that if you take a straight 6 mm incision, it will induce almost 1.5 diopters of astigmatism. The purpose of making this incision curved or prawn incision is to try to come into the scleral funnel so that the induced astigmatism is minimal. The ends of the incisions are pushed away as far away from the limbus as possible. So the sagging of the wound is less and the astigmatism induced is less. Now imagine that if you make the incision very much curved, so naturally it goes without saying that the induced astigmatism will be very less. So only the central part, curved part of the incision will take part into the astigmatism, and perhaps it induces less astigmatism than what this 2.8 millimeter or 2.2 millimeter corneal incision will induce. So I thought over the same principle, and with various types of incisions, I have formed my own algorithms. So in my hand, if you take a 7 mm straight incision, the induced astigmatism is about 1.75. Progressively reduce the size of the incision, you get less and less astigmatism. Now instead of a straight, if you make the incision curved, the induced astigmatism is less. So you make it more and more curved, and when you are making a perfect U-shaped incision, the induced astigmatism is almost nil. But this is about the superior incisions. The temporal incisions are comparatively weak in neutralizing or inducing the astigmatism. So even if you take a big 7 mm incision straight one temporally, it will induce around only 1 diopter of astigmatism. So on and so forth. Make the temporal incision little less, little curved, the induced astigmatism is very less. The superior temporal and superior nasal incisions, they act between the superior and temporal incisions. So accordingly, you formulate your own algorithm, have different types of incisions, study how they behave, and then you decide what should be the shape of your incision for a particular given astigmatism. Now to have a perfect effect, always have the center of the incision on the steep meridian. For example, this is a 140 meridian steep. So whatever may be the size and the shape of the incision, preferably have it centered on the steep meridian so that the vector forces from both the sides are operating well, and you can have a good result. Now for this, you will have to sit in different position depending upon the steepness of the meridian. The nose always comes in the way, but you always get half circle in left eye and this another half circle in the right eye to operate. So whatever may be your steep meridian, you can always center your incision on that steep meridian. So these are the SI calculators available on the internet. So put one type of incision in one meridian in one table and find out how it is. And this way you can calculate your own algorithms. Now before going to the videos, I'll just show you a few of the results. Now all the pre-op and post-op topographies, there is a difference of about 20 days after the surgery. For example, in this first case, the astigmatism is very minimal, 0.28. So I'm not induced on anything. I have on the contrary reduced to 0.18 with a U-shaped incision here. Now this is another case about 0.39 superior temporal. So the incision is again shaped exactly based on the superior temporal steep meridian, and you have further reduced it. Now this is a case wherein it is 1.12, little higher astigmatism, but the steep is a superior 97 degrees. So I have a straight incision on the 97. You have to bring it down. So on and so forth, you do it. Now this is a case of multifocal IOL. Astigmatism is only 0.13. Again with the superior temporal curve, you have induced, no, not induced anything, even in spite of a scleral incision. Now this is a case where astigmatism is very high. It is 3.49 diopters and the steep axis is superior. Patient was not according to toric IOL, but with the scleral incision I have brought it down. The induced astigmatism is more than 2 and the astigmatism has come down to 0.64 without using any toric IOL. This is a straight 7.5 mm incision. This is another case, again the astigmatism is very high, 3.3. The patient was the affording type. He could have easily afforded the toric IOL also, but I have told him about the my methodology, and using without a toric lens, here also the astigmatism is significantly reduced. So in the first case, I didn't charge more, so it automatically becomes a charity surgery. But in the second case, instead of paying more for the lenses, the patient paid more to the surgeon. So this I call it as a premium surgery without using a premium IOL. This is another case of multifocal, no change in the astigmatism. Now this is another case. This is a doctor patient who wanted a multifocal lens. The astigmatism was 1.97 and the steep meridian was 170. On auto, it was showing 165. Now, without using a multifocal toric IOL, I just put a multifocal lens, but his astigmatism was brought down to 0.50. Almost it was made spherical. Here I took the incision. 165 was the steep meridian. So this is the left eye. This is a superior nasal incision centered on 165, a straight incision. And this patient, doctor patient, is enjoying a perfect vision. Plano, his refraction is plano, and he is enjoying 6 and N5 vision. So instead of calling it as a surgically induced astigmatism, I prefer to call it as a surgically corrected astigmatism, because the first is like an unwanted pregnancy and second is like a planned child. So even I don't prefer calling it as a small incision cataract surgery instead of SICS. If you apply my methodology, you can call it as a customized incision cataract surgery. To have a better result in all cases, you mark the 180 and 90 meridian in a patient sitting position as you do in the toric IOL cases. Use the markers again for marking the steep meridian, and whatever is your incision, you exactly center on the steep meridian. How much time is left, Mr. Ashish?
If you could summarize, Dr. Boramani, your always.
Yes.
Thank you.
So I'll go to my last, I'll skip all these videos. Now, see, there are two cases who are having, I want to neutralize 2 diopters of astigmatism. But this is not the mathematics. Now there is under correction in this case, it has been neutralized only 1.5. And again with the same type of incision, sometimes there is little over correction. So this is neutralized by 2.5, there is slight over correction. But it might be under correction or little over correction, but whatever your target is 0, it will be either on +5 on this side or -5 on this side. So in spite of an 1 diopter of range, even if there is some error, your end result will be near about 0, because this is the advantage of this technique. Thank you very much.
Thank you, Dr. Boramani.
Thank you, Dr. Boramani.
Yes, thank you very much, sir. For want of time, we take questions.
Can we skip and go to the next, directly the next talk?
We move on to software guided smart incisions by Dr. Rajiv Rao.
Good evening, everybody. Thank you. I thank the organizers for arranging this webinar. I am presenting this world research as this is software assisted SICS, which is the aim of this research is to reduce pre-existing astigmatism in cataract surgery. Can you hear?
Yes, we can hear you. Please go ahead.
If you look at the first, I'll explain the principle. If you look at the human cornea, the vertical diameter of the cornea is less and the horizontal diameter of the cornea is more. Therefore, we hypothesized that because it's more tightly curved vertically, there is more tension in the vertical meridians. Our hypothesis was this factor causes more astigmatism when the incision is placed in the vertical meridians of the cornea. But at the same time, if we look at the theorem by Gauss, then it shows us that if you stretch the horizontal meridian and reduce the tension in the vertical meridian, then if you stretch the horizontal meridian, then the meridian perpendicular to it, which is the vertical meridian, will steepen or relax. And therefore, our hypothesis was if we accurately relax the vertical meridian so that the tension in it becomes 0, then it should not induce any astigmatism. Second extension of the hypothesis was, in this situation, if we properly calculate the vectors acting on the incision, then we should be able to stretch the horizontal or the oblique meridian so much that incision on the vertical meridian corrects this astigmatism. So a software system was designed, which was an illuminated keratoscope was used. This image of the illuminated keratoscope, which you can see on the left, is picked up by the camera and goes to a centrally based server. The server subtracts all other images and colors and exactly identifies the image of the keratoscope by machine learning using artificial intelligence. Once the image of the keratoscope is analyzed, then with the data which has been fed into the system, especially the astigmatism, pre-existing astigmatism, the angles of K1 and K2, then the algorithm analyzes this data and understands how much a certain meridian is to be stretched so as to make the vertical meridian neutral. So the red image shows the stretch in the cornea before starting the incision, and the green line, which is a fixed algorithm produced line, shows how much the surgeon has to manipulate and stretch the cornea so that the green line exactly superimposes on the red line. In this situation, the vertical meridian incision will make the astigmatism, will correct whatever pre-existing astigmatism exists, and it will not induce any astigmatism on its own. Now, this is the surgeon's view in real time, and in this picture you can see that the red line, by manipulating the cornea, has become exactly superimposed on the green line, and this is the moment when the incision is taken. The surgical step involves injecting visco inside the eye through a 1.5 millimeter incision or a 1 millimeter incision. After that, extending a certain meridian by injection of visco inside and by giving pressure outside. This video will show the exact surgical step. The incision is always kept fixed. So the tunnel is made.
Dr. Raut, you have 1 more minute left in your presentation.
So the voice is continuously telling the surgeon is pressing posteriorly with the blade of the knife, also pressing with the forceps in the left hand. In this situation, the stab incision is made. Now for the bigger incision, the cornea will be stretched along the green line. So by manipulating the cornea, one can exactly superimpose the red line over the green line and then take the large incision. Inspired by the initial results, a pilot study of 14 cases was performed. Looking at this table, it shows that the astigmatism, the pre-existing astigmatism, reduced in 11 out of 14 cases, remained unchanged in 1 out of 14 cases, and it increased by 0.15 and 0.11 diopters in 2 cases. With these encouraging results, we are now going to incorporate corneal, horizontal and vertical diameters in our algorithm, and we are also going to incorporate a parameter for corneal thickness to make the algorithm better. A larger study is already underway. Now, basic question we are asking here to the algorithm is, how should the cornea be so that the postoperative shape will be spheric? For example, if we are taking a superior incision and the cornea already has an astigmatism in the horizontal meridian, then 1.5 diopters of horizontal astigmatism is already corrected by this incision. We are going one step ahead and producing a reproducible online audio-enabled system which will continuously inform the surgeon how it works. Now, our K2K system has been developed by our non-profit trust. It is not available for sale, but it is available for research. It is free of cost. Anyone can train with us. Anyone can put a deposit of 3 lakhs for the illuminated keratoscope and take this system, and one can do the research on it till we perfect the system better and better. Thank you very much for the opportunity to communicate and interact with you. Thank you.
Thank you, Dr. Raut. For want of time, we move on to the next presentation. It is Trans-limbal tunnels in phaco section by Dr. M.S. Ravindra. Ravindra?
Screen so that I can put my screen.
Yeah.
Dr. Raut, please stop sharing. So that,
yes, doing it.
Thank you. I'm grateful to various people who coordinated and made this a possibility. This is a wonderful program. I'm indebted to Dr. Lansing and Dr. Amulya Sahu for leading the respective teams. I'm going to share with you a couple of surgeries I've done yesterday. It's got a built-in voice, if you can hear it. Trans-limbal approach. Is that clear, or shall I?
Sir, MSR, sir, I suggest you to please talk so that...
Please talk, fine. This video runs for about 9 minutes. I can cut short any time. Am I audible?
Yes, you're audible.
Fine. The incision starts from the periphery of the limbus or even the anteriormost part of the sclera, and you can see I'm doing the cystotome the way I'm doing. I don't do it on the eye, but to demonstrate how I do it, press it against a hard flat surface, and the bend is only about 45 degrees. It's not a 90 degree, it's a small bend, so that I can, when I'm passing through, I'm not passing through the tunnel, I'm passing through the floor of the tunnel. I'm perforating the floor of the tunnel with the 26 gauge needle, and I'm getting inside. The idea is to see that the tunnel is closed during the rhexis. Rhexis is a problem because the AC keeps shallowing as the viscoelastic keeps coming out, and now this is the enlarger of the tunnel that you made, and it's got fixed dimensions. It's 5.2 millimeters width at the widest shoulder, so my tunnel width is constant whatever surgery I'm going to do. Hydrodissection is again done with a special cannula which is about 1.5 to 2 millimeter bent at the tip. The first thing that I do is release all the attachments between the epinucleus and the cortex. After doing hydrodissection, it separates the cortex from the capsule. Rotate it. You saw that there is no pull on any aspect of zonules or no pull on the capsular bag. So it's even for a very weak capsule, this is very compatible. To remove this nucleus atraumatically through the tunnel that I have made, I'm bisecting it. While bisecting, I'm injecting the viscoelastic HMS through the cannula. This is a 25 gauge cannula, so that the moving nucleus, which can be hazardous to the endothelium, is protected from damaging the endothelium. As you can see here, both the pieces have come outside. A couple of wire vectors have been manufactured, designed, which will help the different kinds of the nuclear material that you would like to say. So when you are aspirating the cortex epinucleus, it's nice to do it with Simcoe cannula. Simcoe cannula, this cannula is mounted on a silicon bulb, so there is no continuous infusion, and the amount of fluid you are going to inject into the eye, the amount of fluid you're going to aspirate with your left hand using a good quality 5 ml syringe are controlled so that it keeps the anterior chamber formed all the time. There's no continuous flow into the anterior chamber, so the ballooning of the anterior chamber, that's pushing of the posterior capsule backward, is not there, which is very important in a case where you have a weak posterior capsule, like in a posterior subcapsular or capsular opacity. Unfortunately, this tunnel will not allow me to put, I would have loved to put the lens without folding it. That's my favorite way, but here, because the tunnel is smaller than 6 millimeter, I am forced to do injection. So this is another case. You can see here, I'll just brief you as to how I go about. Initial approach is vertical. I'm going vertical till I find resistance. You should not be going through conjunctiva. I find the plane here is probably 1/3 of sclera. You should not go deeper than that. As you go across, have a retroillumination so that you know exactly if there are folds in case you're going near the cements. Once you reach that point, you go down And the moment you enter the antechamber, again make it parallel to the cornea. So it's a 4-plane incision, not a 3-plane, not a 2-plane incision. It's a 4-plane incision which is very tight. And what I'm trying to do is trying to tell you is the anterior, whatever learning tricks you have, the anteriormost line of the tunnel should be straight, and the posterior also should be straight. So both are important. Otherwise, if it is like that, or if this is like that, the tunnel is weak, it's going to leak. So these are parallel edges of entry and exit. You watch this enlarger, I'm applying pressure on the limbus. If I don't apply pressure on the limbus and then tilt it upwards, as you can see, the cuts that extend are coming backwards, they're not going anteriorly. So the cuts as they go and laterally should not go into the limbal area. It should be more on the scleral area. There's a tiny flap of conjunctiva that you have created, and that is the one which seals immediately, unlike any other. And I'm not worried about the conjunctiva because in phaco-incisions it has to be clear incision. If conjunctiva is involved, it starts ballooning. So that episode doesn't occur here because the fluidics is very small. Zonules are not damaged, whatever maybe it is. And you bisect it, I'll go a little fast, bisect it and remove each piece separately to save the time. And aspirate it. There is an IFIS in this patient, but again it does not consider because fluidics is very, very low. It's a low fluidics, low inflow. The entire surgery you need about 25 to 30 ml of fluid, that's all you need. And the pressures are low. At no point of time I'm pressurizing the anterior chamber. The depth of it is as good as a normal post-operative or pre-operative anterior chamber depth. Here, summarize? I'm running it fast. So I'm injected the lens. This is another mature cataract. That's the end of mature cataract. This is the advantage. This is a 25, 30-year-old. The glaucoma surgery was done. I cannot. The entire area is having a bleb, and now you can see beautifully. You can do rhexis there, and without zonules will be very weak there. So you may break the capsule and zonules at any point of time, and without any efforts, you can bring it to the anterior chamber and bisect it and take it out and put a lens there. So the advantages of the technique are evident. There is no need to hydrate it. I have not damaged the tunnel at any point of time, and there is no need to hydrate because you're not stretched the tunnel. Though it's a relatively larger, it's done with one single incision. No need for the side ports in this technique, and the results have been magnanimous. The first day, the post-operative, the on-slit lamp, you'll have very clear cornea. That's what you should aim at, whoever is doing it. And it's done in a tropical anesthesia 100% of the time. And this is the way, I think, this is one of the ways in which you can give very good vision to the patients. Thank you.
Thank you, Dr. Ravindra. With that, we come to the final presentation of the day. We are going to talk about results of simulation-based training with our Indian partners. I am Dr. Ashish Bachau, and I'm quickly going to take you through the results of training on simulation with Indian partners. I'm a consultant with HelpMeSee for simulation development and training. We have been training on the simulator with a course. Previously, we had the tunnel construction software ready, and we have been fortunate enough to have partners from across Mumbai, MGM Medical College, Navi Mumbai, D.Y. Patil, Rajiv Gandhi, Aditya Jyot, to name a few. So we already knew that from feedback from professors of these departments that there is significant improvement in the trainees once they go back to their live surgical training in the respective institutes. What we did was we thought of doing a pilot study to further validate what we observed. We wanted to know if what we are doing is significant as far as presenting a paper or research is concerned. So with that in mind, we went about doing a tunnel construction course, which was a pilot study. It wanted to assess simulation-based training effectiveness. To do that, we wanted to see if simulation-based training was as good as traditional residents. This was an exploratory study. We had trainees from across India, LV Prasad Eye Institute, Hyderabad, Bhubaneswar, Vizag, Shankar Nethralaya, Chennai, and Mahatma Eye Hospital, Nagpur. The study randomized the trainees into two groups, an experimental group and a control group. We had inclusion criteria like residents with minimal or no surgical skills, but good hand-eye coordination and good perception. With that, we broke them down into two groups, experimental and control group. We took them through a tunnel construction course, which we have developed, which was for 6 days. This included pre-reading on an e-book, which was self-study, then doing lab activities together, taking through a didactic classroom, then simulation-based training, which is the bulk of the training that lasts for at least 2 to 3 hours in a day, followed by debriefing and then assessing their performance. Now, the performance of these trainees was assessed when they went back to their respective institutes. The first 20 cases done by each of the trainee was assessed. In the experimental group, it was immediately following simulation-based training, and in the control group, as soon as they had their current traditional training curriculum. We also reviewed their surgeries. We have video recorded and asked experienced surgeon to evaluate these surgeries. We developed a tool for that, which was based on the ICO Oscar tool, so that we know exactly how they are faring. So both the experimental group as well as control group were surgeries were video recorded, then they were randomized and given to masked video editors who did not know which surgery or from which institute the trainee belongs to, and they gave their assessments accordingly on an assessment tool which we built, which was similar to the ICO Oscar. We primarily evaluated them for the complications that they made. Now, for the sake of the study, we distinguished them into major complications and minor complications. Major like a premature entry or a tunnel laceration, and minor complications like a small endothelial touch or an iris touch. So that was the primary criteria for the study. The second was whether they were doing the
I believe we lost your voice there, Ashish.
control group. There was some dropout for
Ashish, we're not been able to hear you.
Some network issue on his side, I think.
Yeah.
Yeah, it's networking for.
You are able to hear us, Ashish?
I think we lost the connection with Ashish.
Yeah, I think we lost the connection.
Excuse me, Dr. Joshi. Can I say something?
Yes, yes, go ahead.
Dr. Srinivas?
Yeah, please go ahead.
Thank you, sir. Okay. In the IOC at Indore, we have conducted a simulator course from the team with the help of HelpMeSee, and I have data roughly around 300 residents who underwent for the training in this under the leadership of Dr. Maniyar, Dr. Bachao, and another people, our national faculty. And
am I audible now? Am I audible now? I think we lost connection now.
The comment
okay.
And then we can continue.
Yes, I would like to finish my presentation. Okay. So, the complications in the adjusted analysis of the 20 procedures.
Sure. You finish, then I will give my comments.
Thank you, sir. Any complication that was occurring was 17.56 times in the control, as it was not occurring so early in the experimental group. We also went about doing the learning curve. The learning curve was estimated for both the experimental and the control group. You can see the blue line is of the experimental group, which was the simulation group. They started at a higher level of competency. They already were aware of how they were, and the learning curve was plotted accordingly. As against the control.
We cannot see your screen.
So we don't see your screen, Ashish, to know about the blue line and the control line.
Can you see now?
Yeah.
Yes.
Yes, yes, yes.
Yes, go ahead, Ashish.
So what I'm saying is the blue line is the simulation-based group, whereas the yellow is the control group. The simulation-based trainees, because of the competency which they achieved in simulation group, already started at a much higher level as compared to the control group. So they did less complications, and they were going through a phase which was steady. They did not show any drop in competency as against the control group, where they started from a very less competency and then went to the to gain competency. So the key findings in our study was that there was a total reduction in the number of complications that the simulation-based group did, both in the major and minor. The trainees in the experimental group had higher overall scores for the 20th procedure than in the control group. They had shorter learning curves and they had better task outcomes. So to summarize, ophthalmology residents who underwent simulation-based training on the HelpMeSee eye surgical simulator for tunnel construction course in M6 surgery prior to live surgery made very less complications, had a good overall technical skill. Their learning curves were shorter, they started at a higher competency level, and they had better outcomes as compared to the control group trainees. We would thank our partners, which is LV Prasad, Shankar Netralaya, Mahatma Hospital, the video editors, ophthalmic surgeons, entire support staff, and of course our patients and trainees who made this possible. I thank you for your attention, and I apologize for the small glitch in the internet that I had. Thank you very much.
Thank you, Ashish, for the wonderful presentation. I think we can go with the panel discussion now. I think everybody can switch on their videos if possible. That would be really great. Yes, Dr. Deepak, can you just go ahead with a quick comment?
Okay, thank you, Dr. Joshi. I was saying that in the IOC Indore, we conducted surgical skill training courses on the same stimulator, which is provided by the HelpMeSee, and not we have done any such type of study like Dr. Ashish is presenting at present, but based on the feedback, I can say that more than 300 candidates have underwent training there on the simulator, and all are very much happy. They are saying that it helps them in understanding even the steps for the first year and second year, and few of them who underwent again after the simulator training into the wet lab on the goat eye, because we are also conducting courses on the goat eye too. They told that it helps them in understanding and making the tunnel better in goat eye after doing first on the simulator and then on the goat eye. That was the subjective finding, not this is the feedback. I am the convener of the SSTC program in the AIOS, and we are taking feedback. So this platform, I would like to share my experience. Thank you.
Thank you, Dr. Deepak. Dr. Ashish, I have a question to you. So how do you feel the difference in, many of us are doing the wet lab. You are able to hear Dr. Ashish? No, I think we lost him again. Dr. Van, I think you can answer the question.
Ashish is there, but I think his image froze. Yeah. Okay.
Internet is answering.
Sorry, go ahead.
Yeah. So now many of us are doing wet lab with the goat eyes. Now they are trying to heat it up at certain temperature where it almost behaves like a human eye, and then try to remove the nucleus of the goat eyes and then put the human nucleus inside it, and they are trying to do it. That's the modification which many of us are trying to do in the wet lab training. So how do you compare the difference between doing it in simulation versus doing it under the wet lab? What do you think are the things which are advantageous and more humanic as compared to the doing it under the HelpMeSee simulation software as compared to the goat eyes?
Ashish is back, so he can answer that, and I can add something that I think maybe Ashish won't say. So, go ahead, Ashish.
Thanks, Van. So Srinivas, the simulator gives you a tactile feedback and visual feedback. Now, we all know that goat's eye do not have the same tonicity or the IOP as a normal eye would have. But with the simulator, we have an advantage that most of us have got a feedback that it resembles a normal eye almost as much as 90 to 95%. So the trainee here feels that he or she's operating on a normal eye, which is giving tactile feedback, which is giving good visual cues. In addition to that, what's simulator and simulation based training is giving is the training tools that we have, which guides them to make an incision or remove cortex or direction of rhexis, and if you make a complication, it actually tells you where you did it. The performance data reflects the same. So in that sense, simulator has an advantage, whereas in goat's eye you would do it once or twice, maybe inject a nucleus, after which you will have to inject some in the goat's eye to make it a little hard. So those are the disadvantages of goat's eye, but simulation you can do say a rhexis 200-300 times in a day without getting tired. The simulator will give you the same kind of eye will load all the time, so it has tremendous value.
Yeah, I think
I can add something.
Go ahead, and then I'll say something. Go ahead.
Ashish,
okay.
We can add
one thing important is in the simulator, even you can track your previous pressure, how much pressure you are putting on for making tunnel, yes, and have your track record, which is very important, which is not possible in the wet lab training, because after the 1 or 2 setting, I cannot show you that how much or which place you are giving more pressure, which place you are deeper in tunnel or that. But in the wet lab, in the simulator, you can track every time that your tunnel is where deep, where superficial, because in these simulators are showing them in a color change format, that now you are in a deeper plane at this, and you can also record your videos too of your different all times of setting. You can see and find out whether you are improving or not. These type of softwares are available in the simulator. No, Ashish, you can say.
That is the best part, Ashish, which you people have done. From the last time we have used it, that you have actually we can know where we are going wrong by your alarm system. That is the best part. Via your direction, your depth is right or wrong, you can know. This is the best part you people have incorporated in the simultaneous last 1 year.
I think the advantage definitely is that you can repeat and repeat the steps where you're having difficulties. And unlike wet lab, once you finish with the eye and the instruments are not cutting anymore, you cannot grasp it. So it has several advantages. The objective measurements, and I think that obviously it has been shown by Anne-Sophia in her presentation and the papers that she quoted that it does increase. Anne-Sophia, would you like to mention something? Because I think your experience is very important there.
I think she raised her hand. I think Dr. Anne, you can add something.
Yes.
I was just going to add that from an educational perspective, to use for the training, for the training of surgical skills, it is beneficial to use several different models because there are pros and cons for all of them. So it's just to say that I am very much into virtual reality simulation. That's also where I do my research. But I think wet lab training has also its place. Yeah. Was there something else that I should elaborate on?
I think you mentioned the educational part of it, and maybe at the end, because when we say simulation, what is simulation? No, there's virtual reality simulation, there's artificial eye. So when people say simulation, they say, what are they really referring as to simulation? So that's an important distinction to make. Thank you, Anne-Sophia. Sorry, I took over the conduction there.
Can I just shortly add? I just wanted to congratulate you on your very nice study that you presented. It's a very well conducted study, and
thank you.
Ashif, one question from you. Lot of young people are watching this webinar. How can they contact you for this training? Can you tell us? Because a lot of PGs are also watching webinar.
Yes, sir. I did share my.
You please share.
Yes, I did share my. Can you see the? Can you
not started? Not yet.
It's screen. Not.
Internet problem.
No problem.
You can tell your mobile number.
Yes. My number. Do you want my number, sir?
Yeah, you can tell the number to the public who can note down.
Yes. Please contact me on 7498 333 711. That is 7498 333 711. And my email ID is drashishbaccab@helpmesee.org.
Thank you.
Thank you, sir.
I have a quick question to Dr. Barun Naik sir and Dr. MSR sir. Sir, how do you think is the practicality of the students coming over to Dubai and getting over trained? And if at all, yes, definitely all know that HelpMeSee, what the simulation they have done is wonderful experiment. But at what stage of the training do you suggest that the trainee should undergo these training, and when should they switch to the wet lab and when to the humans?
If I should answer, it's a very good question, and we don't know much about how to do that best actually. So there are some studies looking at how to do a curriculum, if you should start by doing wet lab or start by theoretical education, but we don't know much about it. I think I would, what I found in some of my studies was that you get something out of the training just in the beginning as total novice, but also when you have been performing maybe that could be 10 or 20 surgeries in real life, because then you have something to add and you get another aspect of the training. So I think you should do the theoretical background, then the wet lab, then the virtual reality, and then patients, and then I think you should go back to virtual reality training, because I think it has something to add there. But we definitely need more evidence on that.
Dr. Srinivas Joshi, may I ask a quick question?
Go ahead.
See, when looking at this machine and looking at the current developments in virtual reality field, would it be possible in the future to convert this machine also into virtual reality, so that I can sit at home, convert, if this machine, I mean, it's definitely possible to convert this entire machine into a reality, virtual reality machine. And then one can sit at home and simulate whatever one wants on a 3D software. So the machine may not be so important anymore in the near future. What is your opinion about this? May I ask the participants?
Yeah, but that's a real brilliant idea, and it is going to happen sooner or later.
Yes, sir. Thank you.
I have something to add, because some of my colleagues at King's have made some studies looking at these take-home training kits for other types of surgery, and there is a difficult. There are some problems when we look at the implementation of these take-home methods, because it seemed like people were not really doing training when it was at home. So even though they had all the equipment and the possibility to train all the time whenever they wanted, they didn't do the training. So that's just another aspect of it that we should be aware of. That sometimes it's very good to have a dedicated area with the expertise to complete the training.
But the possibility always exists of, sorry, Srinivas, go ahead.
Yeah, Barun sir, can we have your quick comments on this?
Thank you, Dr. Srinivas. I think it's development what I have seen in this simulator machine, because first time I saw this machine in Pune that 2 years back. After that time it was in the initial phase, then after 2 years I saw it in Chennai, and that time I also gave some feedback after, but that time again it was only for the incision making, channel making. And later on, because now today what I see now is all modules have been developed, so it's really fantastic. And it's a great service being done by HelpMeSee, because this is something which is surgery for masses, and so many experts who have already shown today surgery with this method and with excellent result. The only thing which I probably always have been pointing out to Dr. Amul as well, that it's basically conviction and dedication of Dr. Amul Sahu why this society is progressing so rapidly. So it's basically all hats off to you, Dr. Amulya Sahu. But
thank you.
But always I have been pointing out, and today also in this forum, because it's a much larger forum, so I will point out that the ISMSICS lacks data, lacks research, and always say like, if so many, like you also showed, oh, mine is very good performance, or this is the pre, that is post, but that is not research. Research, because for the public and for the other audience and your community to get convinced, it has to be in the form of a proper research. And in that direction, the moment I heard something about the first time what Dr. Rajiv Raut is doing, I think it's a great job that he is doing. And once his thing will be out, I'm sure it will change even the outlook towards MSICS. It will change the outlook entirely. So those things. So probably again I will re-emphasize that training part is fantastic for this simulator which has been developed. The surgeons are excellent, and but it lacks research, which probably I will ask everyone to design proper research, conduct research, and publish it. Once you publish, then you become popular and it will be accepted by all.
I think it's a wonderful question asked by Dr. Varun sir. Sir, we discussed about this in our ISMSICS national team. In fact, we are forming an academic and the research committee for the very same purpose, to conduct more and more research.
Just give us 2 years.
Yeah, so we are doing that, and I think it's a very good suggestion from you, which is very required in the, it's the need of the hour now. Now what Dr. Rajiv Raut is doing, now can it be reproducible by the rest of the surgeons of India is again a question. So that is where we are now looking into the research part of ISMSICS, and we have already doing a research wing on that, sir. It's a very good suggestion from you. Just wait for a year or two. We'll have more suggestions from you also. You will be the advisor for our research panel as well. And we would like to know more on this, but I'm very sure as a secretary of ISMSICS, we are definitely working on that to do more. In fact, we want to do something called as one network. That was my dream when I got into it. That is, as the HelpMeSee people are doing, so I request Ashish and our team. What we were trying is, like SF Match Fellowship. I did my fellowship in Toronto. So there is something called as universal thing where you can apply for it, and you should know in the seat matrix which seats are available, which are not available. See, in the SICS training part, the student will be very confused. Where to go, how to approach, which institutes to go, which are the best institutes. So I talked with a couple of these big institutes if they can make it a seat matrix, like one network where all of us can put the seats, how much are available for each institute, so that it will be easy for the postgraduates to select whichever institutes they want, and then allow for them to continue with their secretary. We are not going into what is the fee structure or anything, but from the part of ISMSICS, we are looking to connect these postgraduates to any of the interested institutes they want. So this is already going on, sir. We are also looking into the revamping of the journal, revamping of the video blog, and we are now trying to make it as a one network. So probably in a year or two, I think we will try to do it. Nice, sir.
Sure, that's a great idea. Yeah.
Yes,
BK is the incoming president, so we will do a lot under his leadership. So, and he has been from the beginning with us. From all countries, I think most of the country has come with me. And ISMSICS is a part of ISMSICS from the beginning. Thank you, BK.
Thank you, sir. But one thing that I cannot replace your enthusiasm and dedication.
Thank you.
But you are one of the big pillars.
Sir, I want to ask another question to Karan Bhatia. Karan, you have done your fellowship. Now you are into the mode where you are now into Sitapur Eye Hospital, where many of them are doing. So what do you see the relevance of doing it at present under, I'm not talking about the COVID time, definitely under COVID time, the simulation works best. So what do you think at the present time the younger generation needs? You are now also into the OC. So what do the younger generation needs in the surgical training?
For the younger generation particularly, Surgical simulators, as I said earlier, are the way to go ahead because they do decrease the patients are not, just you cannot butcher patients. So it's very important to give them a stress-free environment in a wet lab where virtual simulators are the way ahead, and a lot of wet lab training has to be stressed particularly now. In COVID times, yes, this is the need of the hour. We have about 30 residents and they are not getting any surgeries nowadays. Sometimes I do give a couple of surgeries to them in my paid cases, whether it be FICO or SICS. But because the entire world of trainees has been impacted, particularly by this virus. So this is the way ahead, and I would actually request Dr. Ashish and HelpMeSee to, if it's possible, to get a virtual simulator at our hospital as well, because we can help you with your research. We have 30 residents, and Lucknow and Bareilly and a lot of places are nearby, a lot of medical colleges and IIOS hospitals, and it will be a good training center for them.
It will be an honor, Dr. Bhatia, and we will connect with you after this call, and we can discuss about it. Thank you.
I think lastly, Neeta Madam is also here. Neeta Madam doesn't have a large experience with the postgraduates around here. We have trained so many postgraduates at Patil Medical College. So what is your take on this? Your final comments, please.
Srinivas, thanks for asking me. I was anyways going to raise my hand to tell you something. Okay, the first thing is like, I'm giving it to you from my PG perspective, okay? We all sit and talk about a lot of things, but we don't know what is going on in their minds. Now, apart from the theoretical lectures, my residents have told me that they would first like to go in for roadside training. Then they would like to go to the simulator, because the simulator actually teaches them the wrist movements, the amount of resistance that they offer, the amount of pressure that they're going to put on the eye, and then they can come back to the original individual patients. So I think your question is answered over here, which should come first. I think the goat's eye training should come before the simulator, and the simulator actually gives them a real virtual perspective of how to go about and operate on a real eye. So this is what my residents have told me, and that is why I'm putting it across to the forum, because most of the residents probably would have the same opinion. Because they said that how to keep your arm, how to keep your wrist, what are the wrist movements, all that is very clear to them on the simulator, because when they make a mistake, the simulator tells them that this is the mistake, which doesn't happen on the goat side. And then when they have mastered on the simulator, they can go back and actually use it on a real eye, and it really helps them to go about doing all these things on the real eye.
And I must
very good suggestion.
Dr. Shanbag has been a staunch supporter and has been sending all of her residents to us for training on the simulator. So thank you.
Thank you, Ashish. Thank you.
She's one no-nonsense lady I would like to mention. So if she's the most unbiased I have seen across in the ophthalmic fraternity and ISMSICS society. So if she recommends, I think then definitely it's a yes.
Thank you, Srinivas. I am honored.
I'll just add one point over here. This is my example. So when I did my first phaco case, so the trainer asked me, have you done phacos before? Because the trainer did not intervene for one single step. All my training that I have gone for about, I did a paid training program before my fellowship. So 10 surgeries was there and no trainer intervened for a single step. And the reason was that I did about 100 surgeries in the wet lab. So wet lab and virtual simulation does make a big difference, and it is the way to go ahead.
Thank you. I think we now come to the end. Dr. Van anybody wants to add quick comments before Dr. Van wants to conclude?
Dr. Krishnamurti from Shankar Netralaya has been...
I want to tell one thing. I agree with Dr. Neetu, and another point that I want to add, which I concur with Dr. Thompson, is that even when we do the phaco simulation, what I found was after the virtual reality and then the both eye hands-on, after they do about 8 to 10 surgeries, if they come back to the wet lab training or the virtual reality module, they know what all mistakes they are making on the human eye. So when they come back to the virtual reality, they are able to focus on that and repeatedly redo the same step so that they refine that particular step, which is their stumbling block. So that is one. Second, I also read an interesting article on evaluating the wet lab by Faruqi et al. So he said we have to evaluate their wet lab training just like we have an Oscar score. We have a wet lab scoring also, because wet lab is monotonous, whatever it may be, and the trainee after some time starts losing the momentum of concentrating and doing the wet lab training. So if there is a scoring system for that, then they tend to concentrate more. And third, we have in India been used to volumes to learn. So we have the trainers themselves have to have a mental changeover, and we have to concentrate more on training in a very small volume of patients. So we have to concentrate on giving quality training more than quantity training. So it is a mental change for the trainers also. And in this, your HelpMeSee and your wet lab practice is going to make a complete changeover. Thank you.
Thank you, madam. Yes, I think final comments from Dr. Van.
Yeah, thank you very much, because this has been a wonderful session. I can see a lot of comments coming on the chat, and I really think that we're all doing this because of the safety of the patient. That is paramount. No, sometimes we forget, and I do this technique this way, I do it that way, and I do it through 2 millimeters or 3 millimeters. I think it's the best surgery is the one that you learn how to do. And the more capabilities we have, we can choose different surgeries for the right patient. I think that's what we all have to do. I really appreciate the help, and I look forward to the next one that we've been discussing, which will be, if I recall correctly, Amulia and Rikshit, 6 on special situations such as low endothelial cell counts, post-PRK, and others. I think, as some of you have already discussed here, and how it's not a surgery that is inducing a small amount of astigmatism. It can even eliminate astigmatism. Also, I think that that concept that it's an out-of-date surgery, on the contrary, I think it's a surgery that will come and have a very important role. On the side of HelpMeSee, I really wanted to thank you, all of you, the company that sponsored ISMSICS and all the speakers. It's been a wonderful session, and I leave it to our friends at ISMSICS to close this session, which I enjoyed very much.
Thank you so much, Dr. Van. It was a really thought-provoking session today. Thank you, Ashish. Thank you, Chetan. And where's the Karta of this event, Akshay Nair? He's missing.
No, I'm here. I'm not on video, but I want to take this opportunity to thank each and every one who's been here, and each of those who are watching at home. Each of the panelists who've, a couple of them have really joined in at a day's notice. And Deepak, who's made it a point to reach out to every resident in India through the AIOS mailer and through WhatsApp messaging, to Entode Pharma for hosting this platform, which has allowed us seamless transmission, to Dr. Amulya Sahu for his visionary leadership in enabling this webinar, and special thanks to each and every one of those panelists for their insightful opinions. Dr. Anne-Sophia Thompson for joining us in spite of this time difference and it being a weekend. And of course, in a special corner in my heart, special thanks to Dr. Sripriya Krishnamurthy. You've been the one who've held my hand and taught me surgeries. Thank you so much. It's been a great, enriching experience for all of us, and a good night to all of you. And I'm sure the video will be available for residents to watch later.
I think we can have the recording of this, and then we can circulate it. I think, Ashish, you can definitely do that. I request Raman. I'm sure that the recording of this will be available to the most of the postgraduates who can take the maximum benefit of it. And
it's already recorded.
Dr. Deepak Mishra, if you give it to him, I'm sure that it reaches each and every postgraduate available in India. What, Dr. Deepak Bhai? I think his connection is not that great.
10%. I will send to all of them.
Okay.
Thank you.
Right. Thank you, everyone.
Thank you.
Have a good rest of your weekend.
Yeah. Thank you, everyone. Thank you very much.
Bye-bye.
Bye now.
Good night.
Thank you. Bye. Bye.